Good morning. My name is Francesco Maura, and I work at the University of Miami Sylvester Comprehensive Cancer Center. And at this ASH, we are presenting different works that might be interesting for myeloma patients. Two works are on how the immune system and the genomics of the disease and the immune microenvironment change over time and respond to our treatment and is involved in the treatment resistance. And another one is a study that was funded by the Philadelphia Multiple Myeloma Network Group and is investigating which mechanisms or genomic mechanisms are involved in the development of therapy-related tumors, meaning you have a myeloma patients treated with the standard cycles, like in particular melphalan, and we know that a fraction of these patients unfortunately develop a second tumor, and usually is a leukemia. Now, it's not a significant fraction, but now that multiple myeloma patients live longer, some can live even more than 10 years, the proportion is expected to be higher. So we show, using our advanced genomic investigations, using a cohort of more than 40 patients, that actually it is not the chemotherapy that causes per se the damage or introduce any alterations on these pre-leukemic precursors. But the leukemic precursors are actually reinfused back using the transplant. So in the transplant, doctors collect your stem cell, the patient's stem cells, and then they infuse back after the chemotherapy. And so we were able to show pretty clearly and convincing way that the leukemia stem cell, or what is clonal hematopoiesis pre-leukemic clone, is infused back and not survive to the melphalan. That's obviously changed the paradigm, because it's not anymore the genomic damage induced by chemotherapy the key player, but there are other players, maybe immune suppression. And we are still working, and we are developing a research program in Miami focused on that. I think it's a very hot topic for long survivor, because if you eradicate the disease for a long time, achieve MRD sustained negativity, the last thing you want is to develop one of these very unfortunate and aggressive tumors. In terms of the other two studies we are presenting, one in a collaboration with NYU, Garrett Morgan and Eileen Boyle, is the first study where whole genome sequencing, meaning we characterize the entire genome, all the different alterations at the tumor cells, are integrated with the single cell of the microenvironment. So we look at both compartments. Most of the myeloma studies just look on one, microenvironment or tumor. So this is the first, and it's nice because we collect patient samples from patients treated with the DARA-KRD cycle, so daratumumab, carfilzomib, Revlimid, and dexamethasone, from the Manhattan trial recently published on JAMA Oncology by Dr. Langren and collaborators. So what we observe is that there are distinct patterns at the genomic level and an immune level associated with sustained MRD negativity and with sustained MRD positivity, and also with progression. That's obviously fascinating from a biological perspective, because it means that the resistance to this innovative multi-drug combination is not just the immune system or the tumor cells, but is an interplay between the two. So if you really want to understand the future of all these new immunotherapy targets, including CAR-T, we cannot afford just to look at one single compartment, but we need to control and investigate both with a higher resolution and comprehensive approach like whole genome sequencing and single cell approaches. The last study, presented by David Coffey in collaboration with the Multiple Myeloma Research Foundation and many other players, and obviously led by Ola Landgren, shown that using single cell RNA sequencing before and after treatment at the beginning of maintenance and 1 year after maintenance, there are distinct immune patterns associated with the sustained MRD negativity, loss of sustained MRD negativity, or sustained MRD positivity. That again is an important factor, highlighting the importance to investigate both the immune compartment and the tumor cell. What was also striking in this work is that autologous stem cell transplant, we know is a very effective drug, but has a very high impact effect on the immune system in terms of prolonged immune suppression. So if you link this study with the prolonged immune suppression, with what I just mentioned at the beginning on the therapy-related myeloid, these two studies are very well concatenated, because one showed that there is a prolonged immune suppression, and the other one showed that probably the CH pre-leukemia expand thanks to this immunosuppression. So this introduces an important concept that I think it's not very well developed in cancer, is how the impact of our therapy affect the future therapy. If I wipe out the immune system, how can immunotherapy work if you don't have the immune system? So these are obviously very complicated concepts, quite unexplored due to the heterogeneity of the treatment, but it's essential to understand why certain patients respond and why not. We can do all the sequencing we want, but maybe the answer is just because the patients received daratumumab just before CAR T. I'm just saying an example without any data supporting it, but that's just an example. It's important to analyze the data in a proper way and combine all these multi-omics assays.
And that may help us with the future of how to sequence therapy.
Yes. Obviously, the paradigm now in multiple myeloma is that we treat every patient in the same way. VRD, KRD, data KRD, according to doctors' beliefs or data, and there is a lot of discussion which is the best treatment. But the point is multiple myeloma is extremely heterogeneous. So we need to do more to identify patients that can just do better with VRD or maybe just RD, other where transplant is useless, other where transplant is mandatory, because we cannot treat everyone in the same way because the disease is not the same way. And there are always the old studies from, for example, the Italian Gemema trial 2008. 15% of patients are still in remission just with thalidomide, dexamethasone, 4 cycles and transplant. So it means that there are tumors that can be cured with much less therapy, reducing the toxicity, the stress, the long therapy maintenance, the exam, and also obviously the quality of life.
Personalized therapy for myeloma.
That's a great summary of what I just said.